Good afternoon. It's a nice instruction course which I have formulated. We named it Uveitis, is it sour grapes? So today we will know that the uveitis, is it sour grapes or not? We have got 6 speakers, and we'll start with the anterior uveitis, the intermediate uveitis, posterior uveitis, pan uveitis, then uveitis search for the cause, and finally I'll talk about immunomodulators, biologics, and corticosteroids. So we'll start with the anterior uveitis. Don't think so simple. This is a title which I've given, and I will hand over to Dr. Partho Pratim. He is from Shankarnetralaya, Chennai. I'm not, he's quite well known. I'm not introducing further. So over to Partho for anterior uveitis. Don't think so simple.
Thank you, sir. So am I audible, sir?
Yeah.
And you can see my slides also.
Yes.
So good afternoon, everyone. First of all, I would like to thank JB sir for giving me this opportunity. My topic is anterior uveitis, and I'll be highlighting that anterior uveitis is not so simple. So before beginning, this is a slide for the audience. If you have any question and it remains unanswered, or you are watching this recording in YouTube or some other social media, you can mail your query to drparthopratim@gmail.com. I'll be happy to answer your query. This is a case of 21-year-old immunocompetent girl presented with anterior uveitis, and you can see there were small to medium-sized KPs, and she had raised IOP, and there were some vitreous cells. So when we dilated and examined her, this was the case. So acute, it was a case of acute retinal necrosis, as you can make out from the confluent patches of retinitis 360 degree. So it's very important to dilate each eye and examine the periphery carefully, even in you are dealing with a case of anterior uveitis. Until and unless you examine the periphery, you can't make out that you are dealing with such a dreaded disease. So in anterior uveitis, make sure that the predominant site of the inflammation is anterior chamber. There can be some spillover inflammation in the anterior vitreous, but make sure that there is no inflammation in any other part of eye, namely vitreous or in choroid or retina. So for that, you need to perform a very meticulous dilated fundus examination. Also, you have to remember to take the history of trivial trauma. Sometimes even the fingernail injury can cause some kind of pigment release or mild to moderate anterior uveitis. So it's very essential to differentiate between the cells and pigments in slit lamp. So also you have to remember that the topical phenylephrine, which we often use with our mydriatic drops, can cause pigment release, especially in elderly individual. There may be a lot of pigments when you dilate them after a long time. So you have to differentiate between the cells and pigments before you call it a case of anterior uveitis. This is my case number 2 and 3 together I want to present. The first one is 40-year-old male and the second was 28-year female. The first patient, there was no complaint of redness and ocular pain. There was minimal blurring of vision for 3 to 4 months in left eye. The young lady complained of severe pain, severe redness in left eye, and also intolerance to bright light. When I checked the other eye also had inflammation in the 40-year-old male, and in female, the other eye was quiet. So it was a unilateral case. So now let's go into this case. The first case, from the history, you can make out it has a chronic course and the insidious onset. That means the patient is not aware how the disease has started. The second case, it has an acute course and it has a sudden onset. And when you further examine, you can see the iris nodule in the first case, absence of congestion, and there are a lot of mutton fat KPs in this first one. Whereas the second case, there are marked congestion of the eye, very few fine KPs, no iris nodule. So you can easily make out that it's a case of granulomatous and the lady is having a non-granulomatous uveitis. So based on that, now we know there are certain phenotypes or certain disease which can present with granulomatous uveitis and certain disease which can have a picture like non-granulomatous uveitis. The same thing I applied and investigated the patient, and the first patient was diagnosed as a sarcoidosis, and the second patient we found the HLA-B27 positive. So Wood's classification or clinico-pathological classification may be an ideal way to evaluate a patient with uveitis in your clinic. So it can give you a very important findings to start examining, lead to that clinical signs and investigate your laboratory test. On the pros of the test, this classification is very easy to apply in your day-to-day practice. The downside of this classification is not definitive. There are often overlapping and pattern changes. For example, the first case I showed, the sarcoid uveitis, the sarcoid sometimes can present as non-granulomatous uveitis also. So you have to keep that in mind when you are dealing with Wood's classification. The case 4, the patient with severe complaint, diminution of vision, referred to Uvea clinic. The patient was detected, the entire finding was detected incidentally when patient came for a routine workup, denied any history of redness, ocular pain in the past, and the ultrasound showed an old retinal detachment. So old rhegmatogenous retinal detachment can have actually anterior uveitis like picture, and you no need to investigate such patients if they are giving history, relevant history. So this is case 5 and 6. This is from JV Sir's archive. Perhaps it's so old that I may not have joined ophthalmology when Sir managed these cases. So the first one is the 32-year-old man with hypopyon uveitis, and the second one was 8-year-old girl with persistent hypopyon uveitis. And both the cases were not responding to the topical steroid and cycloplegic he was prescribing. So at that time, this is, I think you have seen this slide many a times, what is your diagnosis? So the diagnosis is, Sir performed AC tap, and if the first case, he found the filaria, microfilaria, and the second case, there was basophilic cohesive tumor cells, which were suggestive of retinoblastoma. So it's very important that if any anterior uveitis is not responding to conventional therapy, always rule out Masquerade syndrome. Next important point I want to highlight, always pay attention to the iris. This tissue can give you a lot of information. For example, here in first right-hand side, you can see this pattern can lead you to the diagnosis of Fuchs uveitis. The second one, that's iris nodule, can give you the clue that it's a granulomatous uveitis. The third one, that atrophy of the iris, can give you a clue that you are dealing with maybe you are dealing with a viral uveitis. So just coming to my last entity, the treat anterior uveitis in children very carefully. Always remember the signs I termed as ABC. Asymptomatic children, bilateral, band keratopathy with white eye, that means there is no congestion, and chronic codes, beware of these symptoms, these signs, beware of these signs, because this can be the presenting symptoms of signs of juvenile idiopathic arthritis. So referral to a rheumatologist is must. You have to use topical steroid very judiciously, and the most important is you have to follow these patients very closely. I will just conclude with the slides with the mnemonic anterior. Always remember, anterior chamber is involved predominantly in anterior uveitis. No other parts of the eye has significant inflammation in anterior uveitis. Traumatic uveitis should be kept in mind when you are dealing with anterior uveitis. Examination of the posterior segment, especially the periphery, the careful examination of the retinal periphery is must in all cases of anterior uveitis. Rule out Masquerade syndrome, especially in the extreme of the ages. If you are examining a children or an old patient, try to rule out the Masquerade syndrome in them. Iris details can give you a lot of information to decode the cause of uveitis. Pay attention to each finding and always examine the patient before dilatation. And old rhegmatogenous retinal detachment can sometimes present with uveitis-like picture. Beware, don't unnecessarily investigate the patients. Try to take a meticulous history, do a B scan, and then come to the diagnosis. Last but not the least, many of the cases you need to send this patient to rheumatologist, be it a case of HLV27 or as I mentioned in JIA associated uveitis. Unnecessary, you should not treat these patients with topical steroid and oral steroid because these are recurrent conditions and often require long-term therapy with systemic or topical steroid, which may lead to the development of cataract or glaucoma. So referral to a rheumatologist or starting early immunosuppressive can actually help us to prevent this kind of complication in these patients with anterior uveitis. Thank you.
Thank you, Partho. It's a wonderful presentation, elegant. And I'm very happy that you highlighted that fundus examination, even in anterior uveitis, is of paramount importance. Is not only ARN, we can see that even a toxo lesion can be seen behind. And then there is also important thing is that to look into that quiet eye, GIA-associated uveitis, we need to put the patients on immunosuppressive agents as soon as possible with the consultation of rheumatologist. So these are the very nice points you highlighted. Next, we are going to talk to intermediate uveitis, which I title as intermediate uveitis, still an enigma. This is an enigmatic disease, and to solve this enigma and to status of this disease, of the enigmatic disease, we will invite Dr. Kalpana Babu from Bangalore, Prabha Eye Clinic. She will be talking on intermediate uveitis and enigma. Over to Kalpana.
Thank you so much, sir. At the outset, I would like to thank Dr. JB and the All India Ophthalmic Society for this invitation. So when we talk about intermediate uveitis, we are looking at inflammation of the ciliary body, vitreous and the peripheral retina with a known etiology. We call it pars planitis when the etiology is unknown. Now, the characteristic feature for an intermediate uveitis is the presence of the snowballs and snow banking. In addition, you also see other clinical features like cystoid macular edema, neovascularization, multiple scars, and peripheral retinal vasculitis. Investigations are very useful, especially fluorescein angiography and OCT for monitoring these patients while on therapy. Now, these are the different causes of intermediate uveitis, both infectious and non-infectious. And we have come a long way from posterior subtenon injections to intravitreal implants, and from oral steroids and immunosuppressants to biologics in managing many of these cases with intermediate uveitis. So in the next few minutes, I will be discussing few cases which have posed a diagnostic and therapeutic challenge. So my first case is a 32-year-old male with a right eye pars planitis since 3 years on and off on oral steroids. And when he presented to me, he had a vision of 660. So he was referred to me for systemic immune suppression. And when we saw his eye, he has this typical snow banking, snowballs, but he also had these chorioretinal scars. So we investigated him before immune suppression, and we found that his MAN2 was strongly positive. He had mediastinal lymphadenopathy, and when we did a TBNA, he had caseation. So this was a tubercular intermediate uveitis, and we treated him with anti-tubercular therapy, and his vision is 6.6 at 2 years follow-up. Now, contrary to what we have been taught that snow banking never occurs in tubercular uveitis, this is quite opposite. So we did see snow banking in a patient with tubercular intermediate uveitis. Now, our second case is a 23-year-old intern who came to us with floaters, 2 months history, vision very good 6.6. Labs were otherwise negative except for a positive MAN2. Now, during our course of observation, he developed one single granulomatous KP and an increase in vitritis. So we started him on oral steroids and anti-tubercular therapy. But each time we tapered the steroids, he kept getting reactivations, and now he started developing retinal vasculitis as well. So we did an MRI because I thought his disc was slightly blurred nasal margins. So it showed enhancement of optic nerves, and he underwent a CSF examination, which was totally not contributory. So this was his fluorescein angiography, which showed leakages in both eyes, both at the optic nerve head and the vessels. So he was started on steroids with methotrexate. And 5 months later, he is doing extremely well with no reactivations and only on methotrexate. So this is probably a presumed sarcoid, we do not know, but he is doing very well with immune suppression. Contrary to what we see in adults, children pose a diagnostic as well as therapeutic challenge. And this is highlighted by the next case. So this is a 12-year-old Sri Lankan male who had a history since 2013, extensively investigated in Singapore and in India. And when he came to me, he was on MMF and oral cyclosporin maximum dosages. So when I reviewed his records, it was very similar to what I was seeing. So it was otherwise a quiet eye clinically, but fluorescein angiography showed extensive leakages. And this was quite similar when I repeated it a year later as well. So when I looked at 4 years, he was maintaining 6/9 vision with the same amount of leakage. And the only thing we could offer him was biologic in the form of adalimumab, which he refused. So we continued him on the current medications which he was on and continued to follow him up frequently. At that point of time, we stumbled on this article, which was vascular leakages in fluorescein angiograph, which showed that diffuse leakages over a period of time can result in poor visual acuity. So when we saw our next case, which was a 13-year-old boy who had a history since 4 years, extensively treated and investigated, and he had failed almost many drugs. And when he came to me, he was on deflucort, azathioprine, and cyclosporin, and his vision in the right eye was 6/24. So right eye had a cystoid macular edema. Again, everything else was non-contributory. But when you look at his eye, it was otherwise a quiet eye with a very occasional vitreous cells, but he had these cystoid changes in the macula in the right eye. So when we did a fluorescein angiography, we were horrified to see the extensive amount of leakages with optic nerve head leakage even in the left eye. So at this point of time, we thought, let's try tocilizumab. And we didn't know much about this drug or the dosage, but we took the dose which we normally use for Still's disease and gave him every 2 weeks. To our astonishment, this was what we saw, extensive improvement in the leakage. And this was in March 2019, right eye and left eye. And in July, he was doing extremely well. So he received tocilizumab for at least 2 years. And then we stopped it. And currently, he is only on azathioprine once a day dosage. And he's doing extremely well with minimal peripheral leakages. So this gave us a big boost to our confidence in treating these patients with intermediate uveitis. And we thought we had achieved everything until we stumbled upon this case, which was a 10-year-old girl with history of pars planitis since 4 years. Labs were not contributing much. And she was already on methotrexate and oral cyclosporin for 4 years. Parents were already frustrated. And she was also receiving adalimumab bi-monthly since 2.5 years. What was interesting was the inflammation was only in one eye, and her best corrected visual acuity was 6/6 in both eyes. So this was a fluorescein angiography picture. In spite of all this, she had extensive leakage. We did a laser photocoagulation, but did not help much. And we were boosted by the previous case. So we thought, let's try tocilizumab. Unfortunately, what we did is by then we had already had extensive literature evidence and which had said that the maximum dose was 8 milligrams once a month, which was in contrast to what we had given in our previous case. And so we gave her 8 mg per kg body weight once a month. And initially we thought she was doing well until 6 months down the line, when I repeated the fluorescein angiogram, I was horrified to see that the leakage was still present. And in fact, it had gone up a little more. Now, at this point of time, we were led to believe, are we undertreating these patients? Is it a suboptimal dosage we are giving? Or is the drug not working? We still do not know. At this point of time, we have enough evidence to say that 8 milligram per kg body weight per monthly dose is what is usually required. But this is in total contrast to the patient which we treated earlier, who received much higher doses, much frequent intervals. But that patient had history of decreased blood counts over a period of time. Now, considering this in the circumstances which we are in right now, pandemic times, increased hospitalization if you are looking at bi-weekly doses, and now the cost of tocilizumab has also gone up, and the parents are extremely frustrated. We've tried almost everything, but nothing is working. And at this point of time, it leaves us thinking again, see, this is a unilateral uveitis. Patient has a 6/6 vision. There is no cystoid macular edema. Is it worth putting these patients through this extensive amount of biologics? It's something which we are still left pondering. So at the end of the day, though we think we have achieved a lot in recent years, we still land up with patients and we still start thinking whether we are still on the right track. So to conclude, adult versus pediatric intermediate uveitis, again, this is a big challenge. Adult patients usually do well. unlike our pediatric counterparts. Definitely, fluorescent angiography, we are seeing this retinal vascular leakages, and which has also left us with a dilemma. Do we treat them or shouldn't we treat them, especially when the vision is good? However, we do know that biologics have played a very important role in patients with refractory cystoid macular edema. So intermediate uveitis still, to me, remains a big enigma, and only time will tell if we can really get better with time. I thank you all for a patient hearing.
Thank you, Kalpana, for a extremely nice presentation. And with a plethora of cases, you really highlighted the challenge in intermediate uveitis, various presentation. I just want to tell that that unlike like Base's disease, intermediate uveitis also can have diffuse capillary linking, like capillary farming we can see. And sometimes intermediate uveitis can really be a challenge, as you have shown to that one. They can be remain recalcitrant to treatment. You might need to switch from steroid to biology, immunosuppressive to biologics, and even even the change of the biologics can also help. With this, we'll go to that third talk, which is Dr. Rima Bansal. Rima is here. Rima is here.
Yes, sir.
Yes, sir. Yes, sir.
Yes. Dr. Rima will be talking on posterior uveitis, a very important topic. Can we solve the diagnostic dilemma, which often due to the protein manifestation becomes a diagnostic challenge? So Dr. Rima, please. Dr. Rima from PGI Chandigarh, and is quite well known in uveitis field.
So can I present in the end? I am running a parallel.
Okay. So we'll go to the pan-uveitis. Dr. Sudarshan will present that pan-uveitis threat to vision, ultimate threat to vision. Sudarshan, please. 10 minutes. Sudarshan, please. You can go to the slideshow. Slides not seen.
It's seen? Slides
No,
are seen?
just black is seen. But can you move to the next slide? It will come.
Yes, sir. Okay. Thanks, Dr. JB, for the opportunity. So we just saw a not so simple one of an anterior uveitis causing so much of vision loss. Definitely an enigmatic intermediate uveitic. Probably Rima will tell us the diagnostic dilemma in posterior uveitic. But imagine like combining all these three things together and how much will be the risk to the vision in pan-uveitis. Probably you can have a threat to life also, but like at least let's deal with the utmost threat to vision in pan-uveitic conditions. Any pan-uveitic entity with ocular complaints, you make sure that whether it is pan-uveitic or not, you look at the ocular complaints, whether there is pain, redness, or floaters. The type of anterior uveitis can give a clue towards the diagnosis of the pan-uveitis, whether it's a granulomatous or non-granulomatous anterior uveitis. Predominant structure of the posterior segment involvement is primary importance to identify. Almost all pan-uveitic entities have systemic underlying systemic association or systemic features. So, and a contributory history will give you the clue. These are the features in the eye that can present. To make it more simpler with few examples, this is a 35-year-old female with blurred vision. This is a classical presentation of a disc edema with subretinal fluid and headache. Okay, this patient came with headache and meningismal signs and viral prodrome. This patient had Witzels, so we were dealing with an inflammatory condition. So fundus fluorescent angiogram confirmed a clinical suspicion of a Harada's disease. So this is a typical starry sky pattern or a Harada's pattern of a Oaks-Coena Harada's disease. So usually in VKH initially presents as Harada's. A vision threat in this phase in VKH is mainly due to the disc involvement and the subretinal fluid and the exudative retinal detachment. So the important thing in pan-uveitis is how to prioritize your treatment based on which is going to be involved first and how it's going to affect your vision. So in this case, you start immediately planning a pulse therapy of high methyl prednisolone, followed by high dose steroids and later on immunomodulator therapy. Because the vision loss at this stage is because of the disc involvement and exudative retinal detachment. But VKH doesn't end there. VKH can come back with the granulomatous pan-uveitis, again can come back with the subretinal fluid pockets or exudative retinal detachment. So it's very important that you treat the anterior uveitis part also add topical steroids. Oral steroids alone may not be enough. So VKH is one of the primary indication of primary immunosuppressive therapy. So you need to start immunosuppressive therapy as early as possible, so that you don't end up with losing, so that the patient doesn't end up losing vision. VKH not always present so easily. The classical presentation is the exudative retinal detachment and the pan uveitis. This is a young middle-aged female presenting with pain, redness, and sudden vision loss and headache. This patient presented with narrow angles with increased intraocular pressure. So remember that VKH can present with an angle closure glaucoma. A UBM and ultrasound confirm the diagnosis. A ciliary body swelling or rotation can be the initial presenting sign of VKH. So it's important that you don't miss a glaucomatous disc damage and or an anterior ischemic optic neuropathy because of the raised IOP in VKH. You feel like once you have treated with immunomodulatory therapy, there have been studies that show that it can even prevent sunset glow. A convalescent phase of VKH looks like this, clinically appears resolved, but when you look closely, look at the fovea, look at the macula, watch out for vision threat commonly from the macular edema. This is because of depigmentation and clumping. You can have some foveal stippling or RP atrophy, which all can cause vision loss. SSOCT and ICG seems to be helpful in picking up subtle activity even in sunset glow appearance in patients with VKH. So these are indications whether you need to add immunomodulatory therapy, and probably an indication for a periocular steroid or titrating the systemic steroids as and when required. So vision loss in VKH can be in the acute phase or in the chronic stage because of the scarring, CNVM, or complicated cataract. Sometimes the demarcation line also can cause vision loss. They can even cause visual field loss and ERG changes. Some similar condition and more scary one is the sympathetic ophthalmia, which can also present with granulomatous reaction. The posterior segment presentation is almost very similar. You will have subtle subretinal fluid at the posterior pole. The other eye being injured is the giveaway. Remember that the patient can give complaints of near vision defects in these patients, and once you find subretinal fluid at the posterior pole, this is the only eye of the patient. Remember that you need to treat them aggressively and make sure that you give protective glasses for prevention of injury in the other eye also. IV methylprednisolone is the treatment initially, followed by steroids and immunomodulators. So a granulomatous pan uveitis can be VKH or sympathetic ophthalmia, but if you have a granulomatous pan uveitis with significant choroiditis and retinal vasculitis as the predominant involvement, then you're probably dealing with cases of TBS sarcoid. So we just had indications of TB sarcoid, how they present. They can present with granulomatous uveitis or intermediate uveitis, as Kalpana just said. At this stage, generally the vision loss is reversible. You can start off with topical or oral steroids and even periocular steroids if you rule out infection. You can actually wait for test reports of the treatment response in these cases. You can decide about ATT or IMT based on confirmation of diagnosis later, but not always in TB can you wait, because a macular involving subretinal abscess with subretinal fluid cannot wait. You need to confirm the diagnosis as early as possible and treat aggressively. If need be, you need to do a biopsy if ancillary investigations are not confirmatory. As we did in this case, this was a young patient with multiple subretinal granuloma all over. Subretinal abscess was suspected, but all the ancillary investigations for TB turned out to be negative. We went ahead and did an FNAC, which confirmed the diagnosis of MTB, and with ATT and steroids, it resolved very well. You might find that there is a scarring and there is a vision loss, but the other way, at least we could save the fovea and vision was restored. Macular involvement is very risky with respect to vision in TB. The important thing correspondingly in sarcoid is the presence with disc granuloma or disc edema. This needs emergency treatment, IV methylprednisolone and oral steroids, and once confirmed the diagnosis, methotrexate is the drug of choice. In spite of treatment, disc pallor can set in, but remember that central vision can be salvaged even though if there is some visual field loss. We were talking about this macula, vitreous, and all these things. When you are focusing on treatment of the primary pan-uveitic entity, there can be some side thing that can be happening, something like this CNVM, which you shouldn't miss off. So always look out for these things. Along with the systemic therapy, make sure that you pick up subtle CNVM. This is not so subtle. Anyway, we would have picked up in any case. Treat them with anti-VEGF appropriately. So TB sarcoid can involve disc, choroid, or macula, but remember that occlusive vasculitis can also cause retinal ischemia, leading to vision loss. If one disease you're thinking of, which is a non-granulomatous pan uveitis with occlusive vasculitis, sometimes presenting with hypopyon, then you're dealing with Behçet's. This is a 35-year-old pan uveitis with non-granulomatous uveitis presenting with vitritis. So we thought the vision loss in this patient is due to this media haze, vitritis, and anterior chamber reaction. But then when you do FFA, you realize that the vision loss is something more because of the occlusive vasculitis, because of the capillary ferning. Sometimes despite treatment, you might it might go on to disc optic atrophy because arteries and veins are involved. So it's very important that you pick up subtle hints. So for example, look at this patient. This was referred to as intermediate uveitis with vague vitritis. So luckily for us, we didn't miss the subtle hypopyon and the retinal picture of this, which was clinching. So retinal involvement in Behçet's is the only is a giveaway. Is the only non-infective condition where you can get retinal involvement. FFA confirmed the diagnosis, and this patient is on biologicals now. Vision loss in Behçet's can be progressive because of the CNP areas and macular ischemia. Look at this dye; it doesn't seem to be interested in flowing further at all. It refuses to flow further, and we did laser, and after the cataract surgery, vision was still maintained. So it's not always gloomy. Sometimes if you treat it appropriately, you can still salvage some vision. So not just macular ischemia. This is a young patient in from Middle East who was already on biologicals. A patient of Behçet's came with increased cystoid macular edema. This we had to treat with IVMP and hiking up oral steroids. So on and off, you need to treat the acute exacerbation with steroids or biologicals, but always maintain them on long-term immunomodulators. So if you have a retinal involvement in Behçet's, but what if you have a panuveitis with predominantly retinitis? The equivalent disease in the infective part for Behçet's is acute retinal necrosis. This is an elderly male, a patient with renal hepatic disease. We saw the ARN-like lesion in the periphery. Remember, there are some scleral vessels this side also. Interestingly, at this stage, patient may still have moderate to good vision. So at the most, they may have floaters. They may not have at most vision loss. But you can't get away with this. Don't make sure that you cover all the bases. This was treated with emergency parenteral antivirals and oral steroids, and this was a response. But it's not always so typical because this is one patient where the fovea was threatened and we had to do an anterior chamber tap because of the atypical presentation, and it turned out to be PCR HSV positive. So in these cases where there is fovea threatening or into the macula encroaching retinitis lesions, we can augment the systemic antiviral with intravitreal ganciclovir, which is a very good option and acts faster. So necrotizing retinitis, you will have to be always on your toes because it doesn't give you any relaxation. It can give you, it can come back with breaks and RD or a macular ischemia, or the retinitis can involve the disc or cause optic atrophy. So always make sure that you treat them up with appropriate systemic acyclovir for adequate dose, augment with intravitreal antivirals, and be ready for operating. The another infective entity presenting often with panuveitis is syphilis, always a disease of exclusion. RPR TPH titers are suggestive. This was diagnosed post vitrectomy, and this was a HIV patient, so we could make a diagnosis. Panuveitis can sometimes be associated with other systemic conditions. The most important among them is JAA, as was clearly spoken. BSK, cataract, are significant visual handicaps. Remember that amblyopia is most important.
Sorry to interrupt you, sir. We are just running out of time, so you can go towards the conclusion for your session.
Almost always remember that beware of the cheats. Masquerade is one thing that you need to be worried about. So to conclude, common panuveitic entities with predominant vasculitis is Behçet's. If it is choroiditis, is TB. If it is retinitis, it is viral or ARN. Hypopyon panuveitis is Behçet's, and with exudative RD, it is VKH. So remember that almost always they are associated with systemic diseases, and monitor the underlying disease gives you a good thing. Remember that every reactivation needn't be panuveitic. It can present with any of these combinations. Thank you.
Thank you, Sudarshan, for giving an excellent talk on pan-uveitis, which is often a very much threat to the vision. So I am glad that you talked about endogenous endophthalmitis, which can mimic pan-uveitis. So now, if Rima is there, we'll go to Dr. Rima Bansal. Rima, you are there? If not, we'll go to Dr. Ratnam Shivakumar to talk on uveitis search for the cause. This is a very interesting topic and very challenging situation. Rima, you are there?
So my talk is starting in the other session. Can I do it in the end?
Let's at the end you give the talk. So uveitis search for the cause, and none other than Dr. Ratnam with enormous experience will be talking to us uveitis search for the cause. Dr. Ratnam, over to Ratnam is from Arvind Eye Hospital, uveitis services. Dr. Ratnam, please. Slideshow. Dr. Ratnam?
Yes, sir. Yes, sir. Yes, sir. I'm starting my video.
Yeah.
can you help me with I have opened the slides. Do you see the slides?
No.
Your slides are not visible yet. You have to do the slide share option, share screen option.
Yeah, I have done that also.
Then ma'am, just close your PowerPoint and again open it and again share.
Okay, okay.
Or I can
One
present.
second. 1 second, sir. Okay, you can present. I'll do it like you can present, sir, first.
I think you haven't done the share screen option yet because we still cannot see your screen on.
Okay, okay. I'm trying my 1 second.
Yeah, now it's.
This is my presentation.
Okay.
Okay, I will.
Okay, you proceed, sir. You
yeah,
proceed.
then after that you can talk.
Yeah.
It's a little early. After the sharing, Uviatic starting the cause, we put the patient on treatment. I'll be talking on corticosteroids, immunomodulators, biologics. Have you got an ideal agent for the treatment of uveitis? So what has changed over the years? Laboratory diagnostic technique like polymerase chain reaction, imaging modalities like optical coherence tomographic angiography, surgical technique, complex vitreoretinal tech surgery, intraocular injections and implants like Ojudex, dexamethasone intravitreal implant. But what has happened also, we are getting more familiar with the usage of immunosuppressive agents, and biologic agents has come in very much use in treating non-infectious uveitis. But whatever has happened, what has not changed over the years, the corticosteroids, it still remains the mainstay of treatment of uveitis. I'll be talking about immunosuppressive agents in uveitis first. I'd like to share with a story of my patient whom I treated about 20 years back. This is a 12-year-old boy who had injury in the bow and arrow in one eye. And then the patient lost the vision in the other eye with the disc edema, secondary retinal detachment, and Dallen-Fifth nodule. The diagnosis was obvious sympathetic ophthalmia. I treated with azathioprine and steroid. The patient got back vision. You can see the pre-treatment vision, a pre-treatment clinical picture with disc edema, secondary retinal detachment, which completely resolved with the treatment with azathioprine and steroid. This is not the end of the story. The patient, 20 years after, contacted me through Facebook, and he said that he is doing postdoctoral fellowship in Finland, that 12-year-old boy. And he sent his photograph with permission. I'm presenting the photograph. This is a 32-year-old man, and now it is so gratifying to see that the child has done so well. But this is another patient, 23-year-old patient who has a foot and sarcoid uveitis, foot and mycophenolate mofetil, and the patient came back with extensive herpes zoster lesion in the trunk. So that is not always a good story. These immunosuppressive agents can be a double-edged sword. So we should know when to use it, what to use it, and how to use it. So immunosuppressive therapy prerequisite is obviously absence of infection in the body. Reversibility of the disease process should be there. So when I use them, Baser's disease is my top priority. I use the immunosuppressive agents right away, even biologic agents. Sympathetic ophthalmia, VKH, recalcitrant form, I use immunosuppressive agents. GI-associated uveitis, my drug of choice is methotrexate. Serpiginous choroiditis, even I use immunosuppressive agents after ruling out TB. And chronic intermediate uveitis, often it's my first choice. So there are three groups of immunosuppressive agents. I'm not going into the details. First group is methotrexate, azathioprine, mycophenolate mofetil. Second group is the alkylating agent, cyclophosphamide. And third group is calcineurin inhibitors, cyclosporine, tacrolimus. So this is the side effect profile you should know. Cyclosporine doesn't cause bone marrow toxicity, but cause renal toxicity, gonadal damage, not there. But cyclophosphamide produces bone marrow toxicity, gonadal cystitis, and gonadal damage, and should not be given in the patient opting for family. And the mycophenolate mofetil, in addition to the bone marrow toxicity, was hepatotoxicity. Similarly, the azathioprine, bone marrow toxicity and hepatotoxicity. Methotrexate hepatotoxicity is more. So sometimes we use combination therapy like cyclosporine, azathioprine, and prednisolone in recalcitrant box family heart disease or sympathetic ophthalmia. So whether is there any life-threatening risk between the systemic steroid and immunosuppressive agent? Systemic steroid is almost nil. Immunosuppressive agent, yes. So you need to be careful. We need to do periodic follow-up with the appropriate investigation as per the drug is used, hemogram, liver function test, renal function test, and physician's review in case of any abnormal parameters and infection, and promptly discontinue the treatment in case of serious side effects and switch to other drugs like steroids. So in the COVID era, should we use immunosuppressive agents? We need to be very careful, but local agents should be tried first, but continuation of the immunosuppressive agents where the risk-benefit ratio benefit is more. So intraocular steroid implant has come in the long way, is an intraocular intravitreal steroid injection or implant. I am not going to talk on fluocinolone acetonide injection, which is not used that much, and Aujudex implant, which is a biodegradable polymer matrix, which extrudes as filaments and floats in the vitreous cavity. It's a biodegradable implant, and it has got a very good effect in non-infectious intermediate or posterior uveitis. Complication is, of course, glaucoma, 7%, but beauty of it is that it can be treated with anti-glaucoma drugs very easily and do not require surgical glaucoma surgery. Cataract is 15%, but is always treatable with cataract surgery. We have reported efficacy of Aujudex implant in the treatment of non-infectious intermediate uveitis. So there is a cystoid macular edema in this patient of intermediate uveitis. With Aujudex implant, there is a marked resolution of cystoid macular edema with foveal contour again regained. So this is the intravitreal Aujudex implant in the vitreous cavity, which is getting biodegraded. But future therapy of uveitis is biologic agents, monoclonal antibody, anti-TNF alpha inhibitor, and there is a list of the several list of the biologic agents is there, which I am familiar with: infliximab, adalimumab, and golimumab. Infliximab is a chimeric monoclonal antibody, and its dosage is 5 mg per kilogram, 3 doses initially, first day 1 dose, 2 weeks second dose, and 6 weeks third dose. And one need to give methotrexate because it's got immunogenicity as well as folic acid. Infusion repeated in relapses and remissions. So this is a case of basal disease. Is very nicely responded with the infliximab therapy and got the complete resolution of inflammation. Adalimumab is nowadays we are more choosing this monoclonal antibody. Dose is subcutaneous. This is a very good advantage. 40 milligram every 2 weeks. Children 20 milligram every 2 weeks. It's a USA FDA approved drug for non-infectious intermediate non-infectious uveitis. So adalimumab has found to be a phase 3 multinational trial is quite safe and effective, and is particularly the drug of choice in often in juvenile idiopathic arthritis with methotrexate, and if is not responding to the methotrexate in the children. So in comparative study in basal disease, both are found to be equally effective, but the long-term follow-up adalimumab is found to be more better outcome. So long-term outcome of treatment with the biologic agents treated with the active non-infectious intermediate posterior pan-uveitis, success rate found in a single center mode fields 87.2%. In our series of biologic therapy for refractory cases of uveitis and scleritis, we found 89% showed good response. So now last is the Janus kinase inhibitor, which ability to modulate the extent of cytokine inhibition. We are now familiar with this. This is the tofacitinib or bacitracin. This tofacitinib is in recalcitrant scleritis. We have used a first case reported from India. Before treatment and after treatment, there is a complete resolution of inflammation. Tocilizumab is a fully humanized antibody, and Dr. Kalpana has told about it. It's given an IV infusion, 8 milligram per kilogram of the body weight. Now can be given in the subcutaneous also. And it works very well in the uveitis-related macular edema. So what are the tests you should do before starting biologics? Rule out TB, hepatitis, total blood count should be done, liver function test. So biologics has emerged as a new weapon in the armamentarium of management of non-infectious uveitis. It was based in basis and GI-associated uveitis, but we need more data, needs precautions before starting therapy and not without side effects. So ideal treatment of uveitis is still evolving. We are more familiar with the usage of immunomodulatory drug now, like azathioprine, methotrexate, mycophenolate mofetil. Intraocular injections and implants are getting popular. Biologics and JAK inhibitors are promising options. Thank you very much for patient hearing. So with this, we'll go to Ratnam now, if Ratnam is able to share the screen. Or Rima is there. Ratnam, you can share the screen. Unmute.
Is it coming now?
Ma'am,
Yeah,
some
yeah, it's
help
coming.
with, yeah, your screen sharing has started. Yeah.
Yeah.
Now you are seeing?
Yes, you are audible and you are seeing your slide.
Wonderful, wonderful. I'm extremely thankful to Dr. JB sir for giving me this opportunity and for a nice introduction. We have seen so many classes now, anterior uveitis, intermediate, pan-uveitis, and immunomodulators. And searching for the cause in uveitis is the most important one. I will show you 3 very interesting cases where we were searching for the cause. There was a middle-aged man, 56-year-old, and he was working in a primary health center. Obviously, he was exposed to tuberculosis patient quite often, and he had chronic cough, and his smear was 4+ positive for Mycobacterium tuberculosis. And he was uncontrolled diabetes also. He was very nervous when he came to me. And when I asked him about the past history and the present history, the initial visit was in July 2018. He was on first dose of ATT, 5 months. His CSR was 35 and CRP was 36. Provisional diagnosis, already he was receiving tuberculosis treatment. So we thought we are going to handle one another tubercular scleritis. Unfortunately, I was following up him for months and it was not resolving. Then he came after 3 months. He told he's very, very unhappy and he has very bad time in his horoscope and he left his job also. I was asking why. And he listed all the past histories at that point of time. And he told in January 18th, he had a severe cough. At that time, he was receiving the first dose of ATT and left ear ache at the same time. So otitis media was diagnosed as a case a condition and they suspected bacterial infection and ear surgery was done and he lost his hearing capacity. After that, he completed his 9 months course of ATT, but still he was not getting all right from cough at all. So everybody was worried and they did a sputum examination at least 4 times. Sputum was negative. After 9 months of ATT, his sputum became negative. So people told you were not having tuberculosis, but you have cough. And he had fever and he has reduced sleep, myalgia, arthralgia, as well as cough. Then in June 18 itself, he also had right eye redness, pain, severe headache. For headache, he went to neurologist where he was suspected as a case of fungal sphenoidal sinusitis. So functional endoscopic sinus surgery was done and they aspirated the fluid, but unfortunately fungus was not growing. So they started some antibiotic and even the radiologist opinion was fungal sinusitis. Because of the radiologist workup only, they did the first surgery and they tried to prove fungus, it was not positive. So here is a case who had tuberculosis positive, smear positive, treated for 9 months, but he had a recurrence. In the recurrence, there was no bacteria, tubercular bacteria in the lungs. And the same man had headache, severe headache, suspected as a case of fungal sphenoidal sinusitis, and fungus was not grown. So TB bacilli was not grown in the second attack of cough. Fungus was not grown in the sphenoidal aspiration, and bacterial otitis media was suspected, and surgery was done. Bacteria was not grown. This was the history, and he left his job because he was going one doctor after another, and he had a severe eye pain, and he came to us. Now, the moment I show you the picture, you will know the diagnosis for all these problems. For the eye problem, he came with marginal keratitis, chemosis, scleral congestion, a prominent vessel near the conjunctiva, and marked necrosis of conjunctiva as well as sclera. This is nothing but vaginous granulomatosis with multiple systemic involvement, and seen by multiple people, and multiple different infectious causes were suspected, mainly because he is a diabetic, and mainly because he had 4+ positive Mycobacterium tuberculosis in his lungs. Initially, everybody was thinking of infectious cause, but this is a severe autoimmune cause. So what we did is, we did repeated ESR, it was 102, CRP was 129, C ANCA was positive, confirming ANCA positive vaginous granulomatosis, or as we say now, granulomatosis with polyangiitis. Why do we change this name? Everybody should know. So I am adding one point of history also. This vaginous scientist was in Nazi regime, and he was a very, very popular man in genocide machinery. So now people have decided to remove his name from this disease. So we call it granulomatosis with polyangiitis. So we started rituximab, 2 infusion, 4 cycles, because he was a diabetic also, we wanted to be careful. So 500 milligram in each infusion, and oral steroid was continued. And beautifully he started healing. See, here there is no vessels at all. Absolutely avascular sclera, and the vessels have started coming. This looks like a dead sclera, and now it is alive sclera, and everything is healed with minimum staphylomas. He has become very healthy. In fact, if you compare both the pictures, now he is symptom free, ESR is coming down, and he is under rheumatologist follow-up. So he was the person who was diagnosed as pulmonary TB. He had pulmonary TB, but healed, but his cough continued because of vaginous and polyangiitis. And his bacterial otitis media was not bacterial, it was again polyangiitis. His sphenoidal sinusitis suspected as fungus was not because of fungus, but because of polyangiitis. So this case tells us we have to, we cannot always think of infectious cause. It may be looking like an infectious cause, but it may be a severe autoimmune cause. Now we are coming to a contrast diagnosis. A 40-year-old lady came with bilateral sudden loss of vision. We usually think it is retinitis, bilateral retinitis. Bilateral retinitis in an immunocompetent patient is very rare. Toxoplasmosis we may think, but media is very clear. We thought it could be septic retinitis. And when we asked the history, she had a stent, and it was after calculi removal, they placed the stent inside for 15 days. Because of that, she had candidiasis in their bladder, urine grown Candida albicans, and both eye vitrectomy done, Candida grown in both eye vitreous. So here is an extremely different case. First case, we thought infection, and it was autoimmune disease. In second case, we thought it is toxoplasmosis, but it was candidiasis. Usually we see Candida balls in the vitreous. Here it is bilateral septic retinitis. Because she gave history of stent in her bladder, we immediately did urine culture, and it was positive, urine positive as well as vitreous positive. Here is a very, very interesting case where a man came with bilateral exudative RD. My student diagnosed as VKH. Exudative RD with the left eye cataract also. So we have one fundus picture, and ultrasound also done. Both the exudative RD was confirmed, and we thought we are going to handle a case of VKH. OCT and ultrasound confirmed the serous elevation, and we did FFA in that right eye. He was a diabetic also. There was diabetic changes as well, but definitely there was a silent macula, which is not common in diabetes. There was starry sky appearance, but definitely there is something different. There is no exudative RD. It is not typical of VKH. And when we asked the history of headache and prodrome, he told, no, I don't have headache, but I have a swelling in the head. And he had a big swelling in the head. And we wanted, his ESR was 120, hemoglobin, he was slightly anemic. He didn't have prodromal stage at all. He didn't have KPs, he didn't have vitreous cells. So we thought we are missing something, and we did the X-ray of skull. It had multiple punched out osteolytic lesions, which was plasmacytoma. And we did serum electrophoresis, which confirmed the plasma cell tumor. And further, we did bone marrow biopsy and confirmed the plasma cell tumor, which was presenting like VKH. We thought autoimmune disease, but it was not autoimmune disease. It was Masquerade syndrome. So in uveitis, it can be infectious, it can be autoimmune, it can be Masquerade, and the clinical signs may be shared by all these three groups. And we have to be vigilant at every point of time. And all these three cases taught us so many things. Thank you. Thank you for giving me this opportunity.
Thank you, Ratnam. It's a wonderful cases and a real life story. And it's not in the textbook. And every time I like your presentations.
Thank you, sir.
Is Dr. Rima, he's here? Rima?
Yes, sir.
Can you start?
Yeah.
I just introduced Dr. Reena. Rima doesn't need any introduction. So she's from PGI Chandigarh, and you'll be talking on posterior uveitis. Can you solve the diagnostic dilemma? This is the title I gave.
Good afternoon, everyone, and thank you, sir, for this wonderful opportunity of having me in your instruction course, and respected all my co-panelists and co-speakers. So I'll be talking on posterior uveitis, can we solve the diagnostic dilemma? So I'll start with a few cases. This is case one, a 43-year-old male who presented with decreased vision in the left eye for 5 days, and vision was severely decreased to counting fingers. Now, as you can see in the left eye, there is a coin-shaped lesion right at the fovea, a whitish lesion, little smaller than the optic disc. And when we did a fluorescein angiography, we did not really find any clue except that there was some leak from the edges of the lesion, and we did not see any vitreous cells at this point of time. And the OCT showed us that the retina was involved full thickness in the fovea, and this showed some vitreous cells on the surface of the retina. Now, coming to the past history of patient, the patient was a known diabetic. He had a history of swine flu a month ago with bilateral pneumonitis and a couple of deranged blood investigations like low platelets, high sugar, and the throat swab was positive for H1N1. Now, considering his past history and considering the nature of the lesion, we made a differential diagnosis of retinitis, as the OCT also showed involvement of the retinal layers. So this was an influenza retinitis, which is not a very common disease, but influenza retinopathy and influenza lesions in the eye are known to resolve with steroids. So we started this patient on oral steroid. And to our surprise, at 5 days, his vision worsened, and you can see the lesion also worsened clinically. There's some hemorrhage, and the lesion is spreading horizontally. The OCT, if we compare it with what we saw at baseline, the lesion was almost vertically getting into the vitreous cavity. Now it's showing spread along the horizontal spread, not only along the retinal surface, but also below the neurosensory retina. So we immediately took up the patient for a diagnostic vitrectomy, and as we can see on the OCT, there were a lot of cells on the retinal surface here. So when we did the diagnostic vitrectomy, we took care of aspirating these lesions, these cells on the retinal surface. So we went very close to the fovea, and this aspirate was sent for KOH, fungal smear, which revealed septate branching hyphae, and the pan-fungal PCR was also positive. The blast analysis revealed Candida albicans. So we started this patient on antifungal. So we realized that this was actually a patient of fungal endogenous endophthalmitis, And if we go back to the clinical stages of fungal endogenous endophthalmitis, we have chorioretinal changes without extension into the vitreous cavity. At this stage, it is known as only a chorioretinitis. And then the chorioretinal fungal mass penetrates through the iris into the vitreous cavity, which we saw in our patient. And then this is followed by an extensive vitreous infection. And then fourth stage is stage 3 along with associated retinal detachment. So when we look at what we saw initially, this was the first stage of second was fungal chorioretinitis with vitreous invasion, and we halted this with a timely vitrectomy, removing the debris and treating the patient with oral antifungal therapy. So the lesion healed at 2 months, and we reported this as a fungal retinitis following influenza virus type A infection. This was an early presentation of an endogenous endophthalmitis. The second case is of a 67-year-old female who presented with decreased vision since a month, had redness and pain, and she had undergone cataract surgery 5 months back, but with poor post-op visual gain. She did not have any systemic comorbidities. Now, when we saw her right eye, you can see there are capes, and the vision was just light perception. There is dense inflammation even at the back of the IOL. You can see the pressures were normal. And now, to our surprise, this is again the right eye. On the other, when we focus behind the lens, you can see the vessels behind the lens. So this is nothing but the detached retina, which is just abutting the intraocular lens. The left eye also had capes. The vision was light perception. The pressures were normal. And we tried to take fundus photographs, and fortunately, we could capture something on the optos, wide field imaging. And you can see both eyes are showing exudative retinal detachment. Now, ultrasound showed retinal detachment as seen clinically. There was no mass lesion. The choroidal thickness was increased. Axial lengths were normal in both the eyes and same. Now, our differentials, because keeping in mind that this was a 67-year-old female, first episode of uveitis, first was Masquerade, and then could it be a reg RD, but then bilateral, and we didn't see any break. We struggled hard to look for a break, but we couldn't. Was it a weak age disease or sympathetic ophthalmia or hypertensive retinopathy, uveal effusion syndrome? We had absolutely no idea what we were dealing with. So the patient, we examined her again. She was a thin-built old lady with just 40 kg of body weight. BP was normal, didn't have any lymphadenopathy. So all that we could do was, because we saw active inflammation in the anterior segment, we started her on steroids and atropine frequently, both the eyes. We got her labs done, we got her systemically evaluated in terms of blood reports, ultrasound, CT chest, MRI. We did not find anything that could contribute to our diagnosis. So taking her up for a surgery was the only option we thought we could, so that we could send her samples, was because our first differential was Masquerade. So we took her up for a diagnostic vitrectomy, applied a buccal and tamponaded with SF6 because we made a retinotomy. We didn't find any break intra-op. The only thing that we found was the vitreous and the posterior hyaloid was extremely adherent and sticky. So since we made a retinotomy, we gave a tamponade with SF6. We sent both the vitreous samples and the subretinal fluid for cytology as well as PCR. Everything was negative, and this was post-op day 1. The vision is still light perception, IOP is normal, and we follow her up post-op day 3. You can see the gas receding, and this is now where we start her on IVMP. After we got the reports of the PCR, cytology, we didn't find anything. So the only option we had was, let's start her on steroids. Her vision is still light perception. And this is the, after the 5 doses of IVMP, the right eye is still the same, light perception vision, no, not much change. We switched her, this was the maximum we could give. We switched her to oral prednisolone gradually, and the operated eye, which is the left eye where we did the vitrectomy, vision slightly improved to hand motions from light perception at 3 weeks. No malignant cells, all PCRs negative, so we are still clueless here. But now what we find, once the retina is settled with vitrectomy and gas tamponade, you can see there is subretinal fibrosis nasally, and the kind of fundus now that appears with retina flattened is suggestive of, are we dealing with VKH? So this is where we had the suspicion as the gas started receding. Now with 3 weeks, giving her continuously steroids, the retina started to go back in the right eye. Vision improving only to hand motions from light perception, and we can see the underlying choroidal reflex. So we think we are moving towards VKH, 3 weeks. And this is now where we are starting tapering the steroids. This is the baseline on top. And this is at 5 weeks now, where you can see the choroidal changes, the RPE pigmentary changes. The retina is still showing exudative RD, but much less. So comparing the two baselines, this is the right eye. Now, sorry, this is only the right eye. Baseline 3 weeks, 3 months, and 5 months. Now we have the classical findings of chronic VKH, and only after a long course of steroids. Similarly, the left eye, which underwent a vitrectomy, probably a diagnostic vitrectomy was not required, but when she was not responding to anything, and this gave us a clue when the retina started settling, subretinal fibrosis. So 5 months, she gets her counting fingers 2-meter vision. So the OCT shows subretinal fluid going back, and this is the final follow-up. She gets 660 vision, normal pressures, and we put her on immunosuppressants after that. So her retina is settled, and she is now good vision with ambulatory. She can do her work herself. Left eye. So this is how she is now at the last follow-up we saw this year in February. And this is the fundus photograph of the last visit. And this is how she began, and she presented to us with a severe diagnostic dilemma in both the eyes. Third case is a quick one. A 48-year-old male presenting with this kind of, he has poor vision in this eye, only hand motions. You can see there are a lot of cells in the anterior segment, and there's significant vitritis. You can see exudative retinal detachment, a lot of scars in the macula, and the IOP was not recordable in this eye. It was an extremely soft eye. The right eye on the bottom is normal with 6x vision. Now, the clinical course, if we go back to the history, this patient complains of poor vision in this eye since almost 20 years. He was treated elsewhere as TB neuroretinitis in the left eye. He had an on and off fair response to oral steroids. He would say, I get better when I take oral steroids. His treating ophthalmologist started ATT 3 months ago. And when the LFTs were severely deranged, he was switched to multi-drug resistant TB treatment. His blood profile showed severely deranged LFT, IgG toxo-reactive, and TB quantiferon gold positive, and for which his treating ophthalmologist treated him with anti-TB therapy, and that too MDR TB treatment because he was not responding. So I'll take a minute.
Just give 30 seconds.
Yeah, I'll finish this case. So as the patient had stopped oral steroids 15 days ago, and he said he was doing well with steroids, we restarted oral steroids, and we found that the vitritis started resolving. The exudative retinal detachment started settling inferiorly, and we could see these arrows show that there is a lesion in the upper nasal periphery, and here this is where we suspected toxo. So we started him on Septran DS, and we asked him to ask his physician to start anti-TB therapy. So with follow-ups, 3 weeks, 5 weeks, we could see also a break in this lesion, and the retina was still detached. And this is where we planned him for a vitrectomy. We took him up for surgery, did vitrectomy, tamponade, buckling, and this is how he responded. His vision came back. He's at least ambulatory. We couldn't get all the vision because his macula has lots of scarring. So this is how we started on the left, and this is how we could have him at the end of few months with vitrectomy. Thank you very much. And so these are some of the challenging cases of posterior uveitis that presented a diagnostic dilemma to us.
So, Rima, you did a wonderful job. Actually, my title was a diagnostic challenge, and you put really challenging cases. So I just want to ask the hall coordinator, we have got time for the discussion.
Sorry to interrupt, JB sir. JB sir, sorry to interrupt. I'm Dr. Amit Porwal here.
Yes.
I would like to invite the keynote speaker first, and then after her talk, we can take the discussion.
Super.
Yeah, she is logged in. So we have Dr. Noor Samsia, the backup team. I request you. Yeah, welcome, Dr. Noor Samsia from Malaysia. I request the backup team to please share the screen of a CV slide.
Thank you to the organizing committee for inviting me to speak in this conference. I will speak on Uveitic Glaucoma.
No. Just 1 minute. Back in time, please stop the presentation.
Can we just play the first slide first? Can we just have the first slide? Technical team, just the first slide, yeah.
Yeah. So Dr. Noor Samsia is basically an associate professor and consultant ophthalmologist at Pusat Perubatam, UKM, Cheras in Kuala Lumpur. She has been associated with AIOS since quite a long time, and she's got too many publications. She's got a research work in Malaysia, and I welcome Dr. Samsia for this particular session in AIOC 2021 virtual. So welcome from behalf of AIOC. And the backend team, she is going to share her screen and present live. So don't play her video.
Thank you, Dr. Amit. Thank you to the organizing committee for inviting me. Since everybody is presenting live, so I decided to present live as well. So I'm going to talk on uveitic glaucoma. Essentially, hang on. So I'm from UKM Medical Center in Kuala Lumpur. So uveitic glaucoma is essentially a glaucomatous optic neuropathy which developed because of elevated intraocular pressure from complications of the uveitis or from treatment of uveitis from steroid use. So again, it could either be from the complication of uveitis or from steroid use, either open angle or closed angle glaucoma for multiple causes. Uveitic glaucoma is not the same as steroid-induced glaucoma, but often it can occur concurrently. How do you differentiate these two? Well, uveitic glaucoma occurs necessarily when IOP elevation occur due to either an active phase of uveitis or what we call a hypertensive uveitis in cases like viral uveitis, postnasal Schlossman, and Fuchs hypochromic iridocyclitis, and also in chronic phases of VKH and GIA uveitis. But steroid-induced glaucoma commonly occurs from IOP elevation in a previously normotensive uveitic eye, but upon commencement of steroid, IOP starts to go up. This kind of eyes, sometimes when you reduce the steroid, the IOP can come down. And the mean duration of steroid-induced IOP elevation is normally 2 weeks. So gonioscopy is very important to differentiate between the two. In uveitic glaucoma, classically, you can see peripheral anterior synechiae, and you don't see this in steroid-induced glaucoma, but however, it can occur concurrently, and it's very important to differentiate the two. Why is it important to differentiate? Well, in uveitic glaucoma, normally in active phase, you can treat the uveitis, and actually the IOP can come down on its own. But in chronic phase, normally surgery is indicated. But in steroid-induced glaucoma, you may switch to a lower potency steroid. And if the duration of steroid is not long enough, IOP may normalize once you stop the steroids. But if the patient is already on steroid for too long, the IOP may not come down and they require anti-glaucomas. IOP elevation in uveitis can either occur because of angle changes from peripheral anterior synechiae or pigmentation or neovascularization, or because of seclusion papillae commonly seen in pupillary blood glaucoma, or other things like hypertensive uveitis and steroid use. Viral-related uveitis is commonly known to cause high IOP, and this viral includes cytomegalovirus, herpes simplex, varicella, and rubella viruses. It normally causes anterior uveitis with granulomatous creative precipitates, but the prognosis is generally good because the majority of them respond well to IOP-lowering drugs. However, you can also get low IOP in uveitis, either from ciliary body shutdown due to intense inflammation, or sometimes in post-operative inflammation, or sometimes you can get ciliary cleft from choroidal effusion seen in severe uveitis. So I'd like to share with you my first case. She's a middle-aged lady with chronic red eyes diagnosed when she was 20 years old with vernal keratoconjunctivitis. She was treated with steroids, but she developed steroid-induced glaucoma, and she had trabeculectomy done elsewhere at 34 years old. She presented a few years ago with right eye severe AC inflammation and severely low IOP, and she was seeing 460 in that eye. The gonioscopy showed extensive peripheral anterior synechiae, and the trabeculectomy bled was really flat. So this was what she looked like, a glaucomatous cupped disc with macular striation and choroidal striation as well. And the left eye showed severely cupped disc and a fairly quiet fundus. But the B scan showed diffuse choroidal thickening, and she was diagnosed with posterior scleritis. On follow-up, her pressure was 20 when she was quiet, but every time she developed exacerbation, the IOP came down to 4. And this drop, and she also developed drop in vision due to choroidal folds and macular striation. So what she had was both uveitic and steroid-induced glaucoma. and the glaucomatous damage was advanced on maximum medication and IOP in the 20s with corneal toxicity. But she does develop significant hypotony every time she develops acute exacerbation. And this huge IOP fluctuation is actually not good in advanced cupping. So what are the options? Well, what we did was we did SLT. Surgery was not a good option because every time she develops exacerbation, her IOP was terribly low. So we did SLT in the superior 180 degrees and all visible angles in the left eye. So the pressure now is in the low teens on single anti-glaucoma in the right eye and 4 anti-glaucoma in the left eye. And she was advised to withhold anti-glaucoma whenever she developed exacerbation, and her uveitis is controlled with prednisolone and azathioprine. So essentially, treatment of uveitic glaucoma is medically controlled first. Prostaglandin analog is effective and not the cause of excessive inflammation, unlike what people used to think. And other option would be beta blockers, alpha agonists, and carbonate anhydrase inhibitors. But if we suspect pupillary block, then a peripheral PI either done surgically or by laser is mandated. And if the IOP is not well controlled, surgical intervention is indicated. What are the problems with glaucoma surgery in uveitis? The main problem is actually postoperative hypotony from ciliary shutdown, causing shallowing of anterior chamber and choroidal formation. The options are either trabeculectomy, essentially in eyes which are quiet, but also tubes, either valved or non-valved. To reduce the risk of hypotony post-op, one must really prime the patient properly. Normally, we prime the patients with prednisolone 0.5 milligram per kilo for 2 weeks prior to surgery, and this is tapered within 2 weeks post-operatively, depending on post-op inflammation. And we do avoid combined cataract and glaucoma surgery if ever possible. And also tight sutures, if you were to do trabeculectomy, preferably with releasable sutures. And AC information is only indicated when the AC is flat. Also, if you do put unvalved tube, you must ensure that good titration of aqueous flow is mandatory on table. So you either ligate the tube or stent the tube. Studies have shown that between trabeculectomy and valved and non-valved tubes, trabeculectomy normally causes hypotony, but bevel have been shown to have the lowest failure rate long-term. My second case is a middle-aged man with a cataract and high pressures and glaucomatous cupped. So because he lived somewhere very far from Kuala Lumpur, we decided to do phaco-beveled on him. However, he developed severe post-op hypotony and requires repeated AC reformation. So the lesson to learn here is, if ever possible, do not combine cataract and glaucoma surgery, because the cataract itself causes bad intraocular inflammation and can cause ciliary shutdown. The third case is a 52-year-old man who had high pressures on maximum medication, and goniocopy showed scattered peripheral anterior synechia and a moderately cupped disc. And we did trabeculectomy and MMC on him because of the high pressures. But and on table, it was really tight releasable sutures, and there was no egress of aqueous at all. However, even on post-op day 1, he was hypotenuse. There was, but the AC was deep. The bleb was flat, but even so, the pressure was still low. So because of this low pressure, there was no aqueous egressing through the bleb, and this could not form the bleb. And as early as 2 weeks, the pressure was really high, and we require needling. Fourth case is a young girl who had bilateral anterior uveitis from juvenile idiopathic arthritis, and the right eye had poorly controlled uveitis until she requires injection of Ozurdex, and the medical retina consultant requests for a glaucoma surgery for Ozurdex to be injected. So she had cataract in that eye, seeing 636, and pressure of high 20s on full dose Diamox and all the anti-glaucomas. So what we did was synechulisis, phaco, and put an off-mouth valve back in 2015. So there was no stenting, and we put intracameral dexamethasone at completion of the surgery. and she did not develop severe hypotony, and pressure was in the low teens. However, now she's on middle teens or to high teens on 2 medication. The left eye was pseudoaphakic and pressure was high, 20s with full medication. So we put a non-valve tube back in 2015, and we controlled the drainage by putting a supramid 3O. And so she did not develop hypotony. There was no AC shadowing, and 3 years down the line, her pressure is still in the low teens without medication. So the take-home message is expect both hypertension and hypotension in uveitic eyes. Assess for steroid-induced high pressures component in hypertensive uveitic eyes and treat that, because sometimes the pressure can come down on its own. Beware and take measures to reduce risk of hypotony after glaucoma surgery, and if at all possible, avoid combined surgery. I thank you for your attention.
Thank you, Dr. Samsia. And over to you, JB sir, to continue the session.
We just probably have 5 minutes time. And Partho?
We would like to thank Dr. Nushamsia, who has joined us all the way from Malaysia. Big thank you to ma'am for joining us here for this presentation. It was very insightful. Also, now we can move ahead towards our panel discussion. So over to the doctors.
Partho, there is a chat box. Is there any question?
No, sir, there is no question.
So I think is that we have done a great job. Everybody is stick to the time, and the diagnostic challenge cases which Rema has talked about it is a real challenge, and the way I wanted is that same that he has done. So all the speakers did a good job. I think is that we should conclude, because there is almost about 5 minutes time before, so that we can go to the next session.